Welcome to Airway Answers, expanding your breadth of knowledge. My name is Nicole Goldfarb, and I'm a speech-language pathologist and certified orofacial myologist. And I'm here to help you find your airway answers. We're in this together. Let's do this. Hello, everybody, and welcome to Airway Answers. Notice, Dr. Neil, I have my glasses on because I am going blind because I've been on my computer so much I can't see. So I'm going to wear these glasses as I introduce our lovely guest today. So I have Dr. Nicole Goldfarb here. Dr. Neil is a chiropractor who is in the airway tongue tie space. And this is amazing. I have never had a chiropractor on the show. And I know you do many presentations, you host courses. So we want to learn all about your role in the sleep and airway, breathing, fascia, tongue tie field. So I'm going to do a bio so everybody can learn about you. But what I really want to start out with is an introduction about what we're going to talk about today, because I really want to cover something that a lot of providers have not fully understood yet. And that's the floor of the mouth concept. So when I think of you, Dr. Neil, I think of floor of the mouth, because whenever I see, what you're talking about, your presentations, you're an expert in this concept of floor of the mouth, fascia, body tension, and patients with tongue tie. So in this airway realm, we all talk a lot about tongue tie, oral function, frenectomies. But what if the restriction isn't only the frenum? What if we're talking about issues with surrounding fascia, muscles, whole body tension, and that may be playing a major role in this lingual restriction or this reduced tongue mobility. So we're going to also cover about neck, jaw, body posture, the rest of the body, how it's all connected, what is happening. That is your specialty as a chiropractor and having this whole body understanding. I think chiropractors and physical therapists are amazing people. You probably know my husband's a physical therapist. And when we start talking about body, everything, he knows so much. I am blown away that you guys have to understand so many details about the whole musculoskeletal system from the tip of the toes all the way up to the top of the head. There's so much content. So we're going to just absorb you today, Dr. Neil. Are you ready for this?
Ready. I'm excited.
All right. Well, again, thank you so much for being here and taking time out of your day to delve into this world.
Yeah. Well, I mean, your music, the intro music is like the bass and the so good, by the way. I'm like, yeah, I was ready and I'm readier. I'm even more ready now after hearing that.
Love this.
And your awesome intro. Thanks.
I think everybody also needs to know one thing about you, Dr. Neil, is as we were just talking before I hit record, you've already done a podcast today. I know you just did a course, I think it was last week. Then you did a podcast today. Now you're on with me. You have a lunch break, but you're like, oh, we can go into my lunch break. Don't worry. We're going to make sure you have time to eat. And then you have a 3-hour patient after this. So I want to talk to you later. I'm not going to interrupt myself in my train of thought, which I tend to do, but why you would have a 3-hour session. We're going to go over that. But let's start by talking about who you are. Dr. Nicole Goldfarb. Did I say that right? Goldfarb?
You got it. Really good.
Dr. Nicole Goldfarb, but most people call you Dr. Neil, is an integrative specialist. Dr. Neil's career began healing as a chiropractor, graduating from Palmer College of Chiropractic in Davenport, Iowa in 2008. He developed an interdisciplinary manual therapy system called Functional Mandibular Diaphragmatic Integration, or FMDI. And in this system, he has linked jaw mechanics with cranial, visceral, and foot dynamics, and has synthesized many fields and modalities to comprehensively integrate and unlock whole body pain, tension, and dysfunction. He developed Floor 4, a protocol connecting 4 key areas of the body to floor of the mouth tension, which we're going to talk about today. He works in person and virtually, has created online courses for both practitioners and patients, and he also is teaching this method to healthcare professionals worldwide to apply it directly with clients seeking rapid, lasting transformations. Dr. Neil is often the go-to provider for pre- and post-op bodywork for patients undergoing frenectomies and frenuloplasties. He has helped many moms breastfeed with more ease, less pain, and more success by utilizing his knowledge of freeing tension associated with oral ties. We're going to get so into this because it's not just about releasing the tie and you're good to go. I always stress that. My little saying is a tongue tie release is not a means to an end procedure, but it's part of a larger goal. And we need to keep that focus on the larger goal. And the release might help us get there. But we see so many patients who are like, I want a tongue tie release, or maybe come to us after they've had a release. And we're like, oh my goodness, that wasn't the right order. So Dr. Neal also sees many children and adults who suffer from issues related to tethered oral tissues, feeding, airway, digestion, sleep, and TMJ issues. And you're also an advisor to 2 neuroacoustic companies and utilizes and educates on photobiomodulation. And Dr. Neal, your practice is in Santa Barbara, California, and you also see patients in Los Angeles. So welcome and thank you for being here.
So good to be here, and thanks for reading all of that and making it through. Yeah, I want to say a go-to provider, not the go-to provider. I don't know why that I didn't get that out of there, but yeah, it's a village, right? So when we're working with people, it's like I got a piece that I know and a part that I play in the team. The team is so vital, but yeah, I'm thrilled to be here in Santa Barbara. We moved here just over 1 year ago from Redding, which is like the top of the state. And I know we had started talking at least since the Breathe and Thrive symposium in San Diego a couple of years ago. I feel like that's where I met you. But anyways, I was living in Redding and then moved here, and at least it's closer to you in San Diego. Not exactly super close, but yeah, I'm excited to be in Santa Barbara, dipping into the SoCal mix, bringing resources and being a part of helping families and educating practitioners, like you mentioned.
Yeah, Santa Barbara is a beautiful place. I hope you're loving it there. It's like living in a
Yes,
vacation, right?
totally. Yes.
So great. And yes, Breathe and Thrive, that was a few years ago in San Diego. That was an amazing conference. That it's just an awesome conference to attend. I always urge people to attend by the American Laser Study Club. Really always great. And I'm curious, how did you get into this work? So I assume in chiropractic school, there's not much about airway, sleep, and orthodontics in terms of how we think of it. And I don't even know how much tongue tie is talked about. So how did this become an area of interest for you?
Yeah, not covered 1 second in chiropractic college at that time. I haven't been back to find out what exactly they're teaching now. And I've taught a lot of courses, so at some point I'll go teach ones back at the chiropractic college. But when I got in practice in 2008, it was in Illinois, my hometown. It's just basically a small town in Illinois. I opened up practice and I learned from so many greats and mentors, and learned a whole body approach and knew the body really well from a perspective. And I started to follow patterns on people and started to work with fascia and releasing the esophageal valve. And I just explored how to help people with so many conditions just by allowing their bodies to teach me. So intuition was one of my best teachers. But that then, 7 years or into practice or so, we got pregnant. My wife got pregnant. And then, so when my daughter was born with a tongue tie, and I had no idea what that was, the midwife who delivered all 3 of our babies, so the 2 after that too, she said, your daughter has a tongue tie. And that is really like the portal. When I go through that portal, that's what led me into this. And that story I've shared, but it was 2 weeks of struggle with feeding, and her lip tie, cheek ties, tongue tie were creating such a problem that too much air was getting in, and she was all dealing with all this pain, discomfort from that. She had just the latch was really painful. So my wife was dealing with, I know some moms, you might shudder when you hear this because it brings you back to struggles you might have had, but painful latch that was causing a lot of bleeding from the nipples. And so it was those 2 weeks before we had the laser frenectomy to release the tongue were like years, it felt like, because it was all hours of the night and I was on a physio ball just trying to bounce and then gently get my daughter to sleep or get her back to sleep. I was working on these areas in the body and even in the mouth some. I had never worked in the mouth until then. And then I relied on other body workers who had more experience with me in this. And we had great friends who told us about this with their kids. They went down this journey. So we read Dr. Gary's article on scissors versus laser. And it was like, thankfully we found Dr. Yazdi in the Bay Area who did he's an amazing pediatric dentist who did the laser frenectomy, and it was night and day. I mean, it was a huge turnaround. In that case, I mean, our other two, it wasn't night and day. So we had other journeys with them. But the release in her case was like, wow, so much changed overnight. And then you still see she had open mouth posture. And it, the post-op stretches, I was doing them. I scheduled 15-minute breaks between patients so that I could do every single one of those stretches round the clock that we did them. And Dr. Yazdi said, I've never seen wound site look this good. And I'm like, I joke around about this sometimes when I'm like, well, you're really clapping yourself on the back, right? Like, you're the release provider. But no, I knew what he meant. He was like, you're doing great, Neil, at the post-op stretches, and we're doing well. Lactation was doing well to help. But I started to find these patterns in the body where I'm like, why is her right kidney restricted? Why is her, and I just started to go through, I could list them all. And then I started to copiously take notes on her. And then I started to, so before I leave to other babies and kids and adults that I started to evaluate this on, I quickly began to see a pattern repeat. But then I would address these organs, the muscles, fascia, bones, gently, that were out of alignment. And I found there was like a few months after the release, this neuromuscular window, right? I didn't know what it was called then. I just knew there was change still happening, improvement still needed, improvement still happening. And it was both difficult to travel through this because I was still doing body work. I was doing like an hour of body work on her a day. But thankfully, before the release, it was like a few hours. After the release, it was an hour. It got way easier. And that's really where I learned for her what was going to help her, what was going to help all the issues that she had so that she could get even better latch, even better body relief. The latch got better right away, and the release was so great. But appropriating that through her whole body to bring her whole body into the benefits of the release was something that I really tactically found that I needed to do as a body worker and a dad wanting to see her daughter do well. And it began the template and the blueprint for how I would look at a lot of the babies. I started evaluating all the babies. Half my practice at the time was moms and babies. And it grew to like 75% because I just grew so passionate about caring for these cases. And I just began to see all the babies, kids, and adults. I made it a requirement that I would need to check intraorally as long as they were okay with me, which nobody said no. I mean, very few people have said no in all the years. And I started to see this pattern and get more clarified to where I saw 70 areas in the body that had a relationship to the floor of the mouth. And it was very like clockwork with some variables in there. So that was the beginning of the rabbit hole for me was, a dad seeing a baby, struggle and his wife to then I began to be able to take that understanding and start to help others with it.
Wow. Well, the world is so blessed to have you because a lot of us do have these situations with our child. You're lucky you already knew, you had some insight, you went down that portal, you said, and then now you're able to help so many other babies and families and take that knowledge and spread that. And that's just amazing. And this neuromuscular window that you talk about, I love that. I wrote that down. As you can see, I'm like writing notes.
Mm.
So you have the release. And yeah, great things might come right after. Not always, but oftentimes we see change, but it's not always full desired change. There's sometimes still problems, but there's a neuromuscular window you described going on weeks or months after where we can still instill more change, right? So can you talk about what's going on in that window? And also, you kept seeing with your patients and also your daughter these patterns in the body, and you're like, these patterns repeat. You're seeing this repeating
Mhm.
pattern among other patients. Talk about that window and those patterns when a baby has a tongue tie. What are you seeing in the body?
Yeah, and I think there's, actually, I think there's some others in the field that talk about this window, and I feel like before I ever knew that people were talking about this, I felt it with my fingers and my hands. Meaning, there's wisdom out there on that. But I also say that, like, I'm going to jump to your second part maybe first, because just to help context too, some people might be, I mean, I love your podcast, by the way, and you have some great interviews with some amazing people, and you're great at what you do with your practice as well. I've heard so many good things, but you're also just great at interviewing. So first of all, thanks for doing what you do. It's really cool to sit back and watch. I think the who does this apply to? Like, some people are like, okay, but is this just for babies? Is it just for kids, adults with tongue tie, narrow arches? I mean, a lot of people who are listening are pretty well versed in like what we're talking about, right? In terms of the problem, pharyngeal arch formation issues, when the mouth forms in utero in that 4th, 5th week gestation, that's when we're all born with tongue tie, lip ties, cheek ties. It's at that 11th, 12th week of gestation when apoptosis happens, that cells cleave and these issues resolve if they are going to. But for those of us that are left with them, we've had them since that 4th, 5th week of formation. What I think not a lot of people know is that, first of all, that's true embryologically, because I'm a big student in embryology, and the first 10 people I've interviewed on my podcasts are world experts in embryology. And so embryology says that if we all start with these issues, and then voila, this magic moment at 11, 12 weeks happens where the ties dissolve and the arches open up and proper craniofacial development happens. First of all, that's not that. I mean, we have so many people with these issues these days that it's not like there's a ton of people walking around without these oral restrictions and these palate formation issues. However, what happens in that time when ties dissolve is that the fascial, muscular, bone, or osseous restrictions don't dissolve. They've been there for the whole time. And even at 11, 12 weeks, when the ties dissolve and the mouth shifts, the babies in utero, there's still been this journey up till that point to where the map that I talk about, this map exists on those people. So I even see people who, clear as day, don't seem to have any issues, but their body still carries the memory. So I think this work can apply to everybody out there on the planet who needs help, because you might not have any clear, apparent issues, and let's just say that's too big of a topic, because I'm like, maybe their CBCT scan and maybe their proper airway evaluation reveals no issues. Well, sometimes there is. But what I find, though, is that these muscles, bones, fascia, organs. So it's the right kidney. It's often the thyroid gland. It's often, the sphenoid, and it's often the plantar fascia of the foot. But almost always it's the first metatarsal and the big toe on the right side, because there's this spiral pattern of fascial contortion that happens through the body. There's a lot of people who have studied the deep front line of fascia. Tom Meyer's work, Anatomy Trains, and he's amazing. He's a brilliant person that's educating out there that studied the work of Ida Rolf, who's the original Rolfer. She is Ida Rolf. She created this structural integration manual therapy practice. It's one of the things that I do, along with you add in like craniosacral therapy, craniosacral fascial therapy, visceral work. And we can add in talking about osteopathy and chiropractic, and then movement education is wrapped up into what I do. But I find that there are these vectors with all these issues that don't follow the deep front line. They involve lateral lines of fascia that are restricted. But even that, it doesn't follow this pattern, because a lot of the fascial understanding out there of, how you've seen that map of fascia type from the tongue to the toes, that's based on a model where there is no tongue tie. That's based on a model where there are no oral restrictions. My map of PAFI, pharyngeal arch formation issue map, that has these 70 vectors, is based on when someone has oral restrictions and pharyngeal arch formation issues. What does the fascial line look like? What is going on there? And that's when it becomes a spiral pattern, where we often see, it's the left piriformis that has more tension, and it's the right psoas, and it's the left trapezius, upper trap, and it's the right SCM. And then we layer in all the organs that I mentioned and more. So this becomes relevant because I kept finding, wow, we're asymmetrical to begin with. So we're already born asymmetrically. But what happens when you throw in an aggravant and in a tether, right? Tongue tie, lip tie, cheek ties, narrow arches. What happens when you throw that into the mix? When we have an already asymmetrical structure and we throw in that added tug, it throws asymmetry into, we can say, bad asymmetry. Like we're all born as asymmetrical, and that's not the problem. But it is, how does our body exist within gravity, and how do we exist? Well, then this is getting into the weeds, but when I see people walk and we exist, we have the spring-like buoyancy where we can, kind of walk and buoy against gravity. But what happens when we have tongue tie? We have that tether that goes down to our feet, and then we also have the fascia. We have the cerebrospinal fluid get congested. We have that open mouth. We have that anterior head posture, that glossopostural syndrome. We begin to compress in gravity. So when we walk, we're compressing, compressing more. So what I found I needed to extricate and unlock on people was following a spiral pattern, all of these muscles, fascia, bones, and organs, to free up that compression, to make a decompressed, uncompressed spring and spine, so where the body could exist and walk in that buoyancy. So in that neuromuscular window that I saw 3 months after the release, I knew it not because I was limiting it, but because I was often told 4 to 6 weeks, make sure you stick to that. And some people say you could be okay at 4 weeks. You can, and that's for the stretches, very specifically talking about those, tongue and lip and cheek stretches. But I started to find when I released the kidney, the floor of mouth elasticized, freed up. And then I started to find when I shifted the sphenoid, whoa, even more. When I shifted the foot, when I shifted whatever organs would show up, because everybody's a little different, the esophagus, I would check and I'd say, oh my gosh, that posterior part of the floor of the mouth on the right side under the tongue freed up even more. I would notice the tongue freed up even more, to where these post-op stretches became super easy compared to what they felt like before. So I used reference points of how does it feel when we first start and how does it feel as we go. And for me as a dad, and also as a practitioner who loves helping families, how can I help progress with the least amount of stress or the least amount of force? So I found when I was doing the layers that I'm talking about, the tongue would elevate so easily compared to before, when I was just trying to massage and stretch, because that way didn't often find that it was easy enough. But not only that, some babies are going to cry and it's going to be hard. We get through it, but then it wouldn't last. It was still just as tense the next time. I found that out with working on other babies, because they would come in maybe further along the journey, maybe post-op, like you mentioned, when I hadn't been able to work on them before. And I would have to problem solve this after the release. And I would say, what's missing? Oh, often one of these 70 areas, although I kind of distilled it down to 4 main areas. That's what I teach now. 70 is crazy. We can't, not everybody has all this time and has built that into their practice. I try to teach this in a way so people can, within 15 minutes, get a ton figured out so we can help these babies, kids, adults. The one additional part that I left out was, if I'm seeing this change happen, like, yeah, that tongue's going to elevate more easily. And I realized, wow, that wasn't because of the work I did on the floor of the mouth. That wasn't because of the elevation of the tongue. That was through the shift of the body that facilitated the shift in the mouth. Not only that, the tongue would elevate way more easily. The orbicularis, the buccinators would elasticize and free up without any body work. The pterygoids would open up in length amazingly. Not only that, but especially on these babies, the maxillary arches would soften and spread. The palatine bones, those posterior hard palate bones, would elevate, become more spongier on their own. Nasal breathing, congestion would open up, especially with these babies that have a anteriorly, inferiorly misaligned frontal and nasal bone. And it would shift so much that not only would the mouth and the face and the head free up, it would be this widespread diffuse cascade release through the whole body, where their neck and shoulders would open up, right? Their fingers would unclench, the right trunk would open up, their psoas would free up, the inner thigh muscles, the hamstrings, and the calf muscles would turn to butter. My work is, how much change can I get to have happen where I figure out 1, 2, or 3 roots. And when that happens, the whole body shifts, because way less stressful for babies and people. It lasts way longer because it gets to the root of the issue, and it makes it to where there's a different state of mind that people are in to where everything just feels way more like way easier. So that's kind of painting the picture of what I'm doing in each visit and what I hope for and what I expect and what I learned in those earlier cases, starting with my daughter, going to other patients, and then my other kids. What are the ways that I figured this out? It was intuition, my greatest teacher. My daughter was also my best teacher. And then every single person that came in through those doors really were what taught me what to do.
Right. You started seeing this pattern. And what's interesting is I do see there's a lot of moms who will have the breastfeeding difficulties. The child gets the release, and then the mom comments that we're still having issues or it's better, but things have not fully resolved. So I might see this. I don't work with babies, but I might see this through friends or social media posts. I hear these comments where there was a hope that everything would be completely resolved and it's not. And then the parent might think that wasn't the problem, or maybe the release wasn't sufficient, which sometimes can occur. But from the work you do, you can really see that there's more components than just the release itself. It's freeing other aspects of this interconnected body system. And it reminds me also when I interviewed Dr. Hope Reyes, who is a PT that works with babies and infants, we were talking about torticollis. And she was saying she never starts at the head and the neck, but starts at the lower, at the abdominal area and the hips. And that's where you start releasing and getting mobility and flexibility, and then the head follows. So it's this whole interconnectedness of the body. And I'm wondering if you could talk about those four main areas. You said you kind of have these 70 vectors of like impacts from a tongue tie and how that fascia or those issues are spreading throughout the body, these patterns you're seeing. And you listed a few of them. Are those are just things you start observing through multiple patients? You start seeing these patterns. And if you could talk about the four main areas that you teach and you help therapists and families understand that could really have this greater whole body impact.
Yeah, for sure. And so let me start by listing all 70 points. I'm just kidding. I'm not going to do that. So
As you can go. No.
right. I feel like talking about the babies is so beautiful because, and it's also the time of biggest challenge, unless you have kids that are older, which you do because they grow up and then you have issues then. And I love helping kids in that, any age. I mean, just all through. I had a family. Oh, I'm going to mention this and then I'll come back to your question. But I had a family who, just long story short, I was in the Children's Airway First Foundation podcast. This mom heard me on the podcast. She saw that I was coming to do a Floor to the Mouth tour event in Phoenix. I was teaching an event there, a 2-day training where, just like you mentioned, I teach the floor four. So I taught myofunctional therapists, lactation consultants, PTs, body workers. There was a couple of dentists that showed up, and it was amazing, and how to understand these areas so that we can help our people. That mom heard and she said, if you need a demo, I can bring my 3-year-old in. Well, what's wild is that she brought her 3-year-old in. And it was so amazing. I connected really deeply with that family. And then they came out to California for that 3-year-old and them. They did sessions for the two of them. That was a year ago. And then they just flew out and they left yesterday. But they came to do a 2-day system reset experience that I cultivated into a family experience. That meant 3-hour sessions over 2 days. And then 1 hour of integration time at the beach, mindfulness, because I bring that part of this into it because it is these tongue tie issues, these airway issues, they're mind body too. We need to find ways that we can help people on a deeper level. So that's what I've really tried to do. And I'm one of the many out there who's understanding this. So there were 3-hour sessions that they split with their family members. So they brought, husband and wife and their 3 kids this time. And we fit them in and saw them all and did different, lengths of time with each. And so there were, 1.5-year-old, a 4-year-old and a 6-year-old and the parents. And boy, it was like that whole family needs this help. And they've been on a journey and they've got their, dentists and airway providers and SLPs and myos and they've got all of that. So I'm part of the village. I think what you mentioned, I love Hope. She's amazing. I met her at Breathe and Thrive in San Diego. And I feel like with my floor four, it is a nonlinear path, meaning sometimes the key to torticollis is in the throat. It's in the thyroid. Some people, the key to torticollis is in the dural tube tension up here, but that's not often the first, just like you were saying. She starts in the abdomen, in the core. It's like, sometimes it's the feet. When I unlock the foot, the floor of mouth frees up, and 90 something percent of the torticollis dissolves without me having to work on it. So I'm really looking, where is it all beginning? What's the origin? I think the floor 4 is something that came out of recognizing a pattern on like 90 something percent of my patients and people that I would consult. And what are the 4 main areas of the body that, when unlocked, can have this direct connect to free up floor of mouth? And those 4 areas are the head, the throat, the sides, and the feet. The sides, think love handles. If you want to get nitty gritty, it's QL muscles, kidneys, even the diaphragm or the border of the abs. And then the feet, there's so much to say with what's involved there, but at least we know the foot, the ankle, the Achilles tendon, the different areas that could be involved with alignment. So I kind of started with the sides, went down to the feet. If you go up to the throat, it can involve the thyroid, the parathyroid. It can involve the manubrium, which is the top segment of the sternum. It can involve the hyoid. And of course, if we talk about the head, it could be the sphenoid. It could be the cerebellar diaphragm. It could be the suboccipital diaphragm. It could be the upper cervical structures. There are functional diaphragms that I teach on what are areas that operate just like the diaphragm. The diaphragm is the belly diaphragm, right? But then a lot of people might know about the pelvic floor operates like a diaphragm, and some people know about the mouth, right? The oral diaphragm. The definition of a diaphragm is a horizontal structure that regulates the flow of interstitial fluid. Interstitial means cell-to-cell communication. So that's the definition, meaning, yes, we talk about the belly, but these other areas can be diaphragm. But for people starting out, they haven't had a lot of manual therapy training. I just keep it simple: head, the throat, the sides, the feet. And if we work there in a pattern, we can see the mouth change hugely, dramatically. I've had people who I'm guiding this virtually and I'm consulting them like somebody in Turkey. And I don't know if I'm ever going to see them in person, but I have them work with the floor 4, and I'm seeing it happen, and I'm having them do intraoral afterwards. Their bodies go through this big change, and we're seeing a lot happen with that.
I'm just wondering, is this program or this concept something that any therapist can utilize with their patients, or is this only something physical therapists and chiropractors and people in that realm can use as treatment modalities?
I've had a lot of myos, lactation, even dentists who are using this in their practices, who have come to one of my floor 4 trainings in, Boise, Idaho, Phoenix, Arizona, Chicago. In Chicago, the training that I did, Kevin Boyd also spoke, Milt Gavalis, and then Melissa Mugno. I taught them this, and they're understanding it. So I think it's applicable to anyone who works with anyone who has these issues. And yeah, it's a little more catered to those that are in the airway feeding world. So if you are guiding patients through care, but I have myos who only work virtually who have still been able to implement this. But that's the floor 4 training, and it is really great. I've so many testimonials. I've taught that in different places, and then I just taught it here in Santa Barbara. Was it last week? Oh my gosh, this time is so full because that family came from Phoenix. They just left yesterday, and then the 4-day training was Thursday through Sunday. So I had the floor 4 training on Thursday, Friday, and then I had 3 of those students stay on for the advanced training, which was functional mandibular diaphragmatic integration, FMDI. So that course, yeah, that's for hands-on people, because they're going to, so Shalom Samuel, she's an amazing chiropractor, SOT practitioner who works in the airway field in Wisconsin. These are the 3 first people I've trained in my advanced work, and they are, I believe, amazingly equipped to handle things on a deeper level than I've seen anybody that I've trained before. Then we have Stacy Goodwin, who's in South Carolina. She's a pediatric OT, but she does CFT and fascial work. So that helps her with this, because the advanced work is really for those who are going to put their hands on people to work with them. Then we have Jeannie, who's her handle on Instagram is Invisalign Gal. That's not all she does. She's an airway dentist, a myofunctional therapist, and she does buccal massage and nervous system work with photobiomodulation, red light. So they went deep dive in for this advanced work, which was really meticulous. But I'll scale back to the floor 4. That is for everybody. So I've got in the works is a 3-tiered system that's coming out, where there's a version for anybody out there, patients, clients, This is helpful direct to them. But then there's floor 4 for practitioners. That's who I've had at these trainings, for practitioners to understand this and how to work with their patients. But then there's the floor 4 for organizational levels. That's when you want to implement this on an organizational level, usually if there's a practice that has multiple practitioners. So I'm going to Infinity Neuromotor Development Center in Iowa. Josh Madsen, he's a chiropractor who specializes in autism, neurodivergence, and phenomenal work with lasers. So I'm going out to Iowa to the home base. He's flying out their offices from Denver and Minnesota. And so there's like 25, 30 practitioners who I'll be training in the floor 4 and parts of the FMDI training. So they're going to carry that floor 4 as a organization who knows this, because I really believe it's going to be standard of care for how we help people with the mouth when it comes to freeing up their restrictions in the fascia, muscles, organs, but the floor of the mouth being a pivotal part of that result. And he has SLPs, OTs, he's got the whole kind of gamut of people on his team. So we're really excited for that. So I'm just trying to, how many more people can I share this with? But more than that, how many practitioners can I share this with so that this work can really help to make it easier for people to receive the care? But I think you mentioned something that really hits, like, I've seen so many people come in. Let's just say I'll start with like the 𝐃𝐈𝐒𝐂𝐋𝐀 age range of like anywhere from 4 years and up. But these kids, like yesterday, the 4 and the 6-year-old, they both have diastasis recti abdominis. That's when the abs have separation. And a lot of people will think this is from postpartum. Moms get pregnant, then the belly widens to allow for that expansion of the belly. But every baby's born with diastasis, and developmentally, it's supposed to close at a certain point. Stanford has an article that says most cases of diastasis will resolve by 5 years of age. But Neil, as a practitioner, is not seeing that, right? I see like 80-year-old men who have those bellies that are way out there. The ribs are flaring in extension, and it's not beer. Some people it is, right? It's a beer belly, but no, they're like, it's not that. It's diastasis. And I can feel the valley between the abs, and I can see they've never had surgery. So it's not from that. But bringing it back to like the 4 and the 6-year-old, when I see ab separation playing a role in airway cases, it is often for me the most overlooked area. They've seen the best body workers and manual therapists, and they have great support with myo. But what's being missed is the diastasis. And I've even had people who are there like, I wondered why I couldn't, my 6-year-old can't hold this posture. Normally we'd think, oh yeah, it's because of those rounded shoulders. It's because of the collapsed airway. But what does collapsed airway mean to the body? Collapsed airway means it's a midline issue. So that means midline structures like the linea alba of the abs, that's not formed as well. It's harder for the brain to integrate the abs. So I work extensively with diastasis, especially with kids, because that's often where I see those release procedures, even when they have a recessed retrognathic mandible, even when they have all these things and they're getting expansion, it's stressful to their bodies and their nervous systems. And even though they might have sensory processing issues, even though they might have a lot of these manual areas that need to be released, I'm often finding that when I help their diastasis, it helps so dramatically with their bodies being able to hold their posture, and with their floor of mouth freeing, and with their jaws coming forward naturally and holistically. So I work very methodically on that. And that's why where photobiomodulation comes in, because some people might think, yeah, we got to do cross crawl and midline integration. Those work unless you have tongue tie and airway issues, and they don't work as well. So I'm releasing kidneys, re-architecting the rib cage gently with babies and kids. I'm shifting their whole frame to allow the abs to come together. But for some, violet light intraorally at a specific place on the maxilla works dramatically within 30 seconds to help integrate the abs. And I would say that there's a very fine line with when to use that, although it's never harmful for the mouth, to you then do structural work. So that's where that's where I taught these 3 practitioners how to know that, because I think that's one of the most overlooked things that I'm seeing. The floor of the mouth, yes, the floor four, even more are overlooked. I rarely see those being addressed on people when they come to me and I'm seeing these difficult cases with failed tongue tie releases, or why is somebody's palate not expanding symmetrically? The floor four is the biggest area that I see and it's not addressed thoroughly. Add to that diastasis, and when I see diastasis improve, oh, I see so much more ease. Whether it's the baby who has the retrognathic mandible and they can't get that jaw forward, and their hypersensitive gag reflexes won't calm, or it's that child who can't regulate their nervous systems and their palate won't really expand easily, and they, in adults who are getting MAD. And I love all these things, by the way. I'm such a fan of all these procedures. MAD, mandibular advancement. One of the things I'm pretty binary. I'm like, what's not working with that mandibular advancement? Thyroid or parathyroid or hyoid that hasn't been released. So I've seen so many people who their bodies are stressed out in these processes with releases, expansion, advancement, and double MMA and all these. And I get to collaborate with some of these amazing providers out there in the world who are doing masterful work. But I believe with the Floor 4 and FMDI, these systems emerged from a place of helping these issues, whereas chiropractic doesn't know anything about tongue tie. Chiropractic doesn't know anything about airway. And, they don't teach anything about it. And I didn't learn anything from that. And like you've had to go deep and learn so much more. And like your husband, I've heard so many good things from you guys and from others about how much you know. So I feel like we need to go down the rabbit hole, and that's been my journey of what else can I figure out to help these people, because there's a lot going on.
And it just really keeps reinforcing the fact that the body is interconnected. And when we have any technique, whether it's an appliance, an orthodontic technique, a surgical technique, or release, it's never a one solution, a one size fits all, or a one step solution. We have to address other components and compensations that have developed through fetal development, right? Even at
Yeah.
such a young age, we're born with certain issues or patterns. And I find that rectus diastasis really fascinating. I do have that issue in my family line. I see that rectus diastasis, that postural issue. And I'm wondering, is that genetic? Is it a strength issue, a postural issue? Is it part of the glossopostural syndrome? And when you're treating and correcting that rectus diastasis, is that entail muscle strengthening of the abdominal area, pelvic floor, diaphragmatic breathing? Like, what do you do to help with that?
Yeah, and I mean, one of my favorite people to collaborate with in this, aside from amazing, so there's so many amazing providers I could mention, but a pelvic floor therapist is somebody we have such a flow with diastasis, because diastasis is navigated by different practitioners, but physical therapists who often then add on training to be pelvic floor therapists get the most understanding about it. But that being said, there's amazing practitioners out there who don't do pelvic floor that are also really knowledgeable about diastasis, because looking at things like you're saying. So I do think there's a lot. Breath work in proper diaphragmatic breathing is really important. Muscle strengthening, and again, I love collaborating with. We haven't directly, I haven't collaborated with your husband yet, but I feel like I will. And it's the more I went down to San Diego once to see patients, and I know I'll be back again. And I'm sure there's such a great, the training part. And I've collaborated with like trainers in different cities where we need the brain and the body to learn strengthening training so that it all makes sense. And I do incorporate some of that, but I rightly refer and defer to others who carry that part more than I do. I really go into, with this DRA, where does it come from? How can I help the root causes of it so that I can support those people in an area that I can help with, and then bring on other people or refer to other people who carry other strands of knowledge. But I think it starts out embryologically, like you mentioned, when the mouth forms. I have my students now, I have them draw the pharyngeal arches and label where what forms and when, and in these different arches. But yeah, I think so much starts in the mouth. And then a little preview of some of this is the diaphragm starts in the throat at 5 weeks. So when tongue tie, we are born with these restrictions at 4 or 5 weeks. And then when the mouth forms, the diaphragm forms here at 5 weeks. When at 6 weeks, it makes its way down to the thoracics. And then at 8 weeks, it lands in the belly where it is now on most of us, right? The belly diaphragm. That journey is a tethered, restricted fascial journey. So I do think that's one of the main reasons why this midline issue with diastasis, it's hindered, where I do see more people with these mouth issues, tongue tie, neuroarches. The midline is not integrating as easily. The linea alba is not connecting as easily. And there are more instances of this ab separation that are going on. So I think it's carried through the family line because of those issues as well.
Interesting. Yeah. I mean, you see these postural patterns in families. And I
Yeah.
do see that kind of like belly hanging out, thoracic kyphosis, like that sort of glossopostural syndrome, but that kind of loose belly thing. And so how do you treat that? Like, what would that look like in a session with you doing these different techniques?
Yeah, I'm going to mention like the part that's very unorthodox, and then I'll say, but there's like a really good, like more basic plan that I think can help a lot of people. In a lot of people, I'm going to do violet light cold laser, and I'm going to do that. I'm going to do my floor 4 to free up these areas to allow the floor mouth to elasticize. I'm going to do body work on the ab muscles. I'm going to adjust all the visceral strains, all the organs that are out of alignment. And my work is kind of characterized and hallmarked by, why do I spend 3 hours with some people? Because I'm going to work on them lying down, sitting, standing, walking. I'm going to work on them in manual therapy to acclimate them to gravity, to shift them in gravity where their misalignments and distortions occur, so that their bodies can hold on to that suppleness as they lie down, sit, walk, and do all the things that they're designed to do. But for the diastasis, I'm also going to work on the repatterning that needs to happen. So I'm going to get them into, I used to teach intuitive movement around the world, and I pull from my intuitive movement practice to help them go into movements that are flexing and extending, crossing midline, these movements later on to help out, so that you're training movement patterns in the brain. In mindfulness parts, I teach people how to build up the hemispheric connection of their brain. So teaching them how to write in cursive if they don't know how, like a lot of kids don't know how to write in cursive, right? Teaching them how to write in cursive, that unites the hemispheres. Dance, I incorporate dance as a dance movement therapy, and as my history as an interpretive dancer, I found huge benefit to my own diastasis by dancing. Not dancing like turning on music and just doing, although you could, right? It's like slow, poetic, fluid movement, or ecstatic dance where you're really letting your body lead you. Then there's a lesser known supplement, monatomic elemental gold. Gold has tremendous properties of bringing the hemispheres into integration in the brain, because I believe the brain is a big part of what can happen with diastasis. And then again, some others, I'll say, okay, I've seen improvement here in your diastasis, but now as soon as you go into prone, AKA tummy time, right? For babies, toddlers, tummy time for parents. We're going to say prone because most of them don't think of tummy time, but they go into like that prone posture, and I'll see, oh, wow, that their diastasis gets way worse because that kidney misaligns. And so I'm working on them in prone, but I'm also going to say, okay, let's have you practice tummy time, right? A lot of people have heard about practice crawling, getting on all your fours and doing all these army crawls, cross crawls. I think some people need to start back out at the tummy time they never got, or the tummy time they never got with a freed mouth and airway, because that's often what is hindered, is the tummy time when their tongue was tied or when their oral restrictions were playing a bigger role, their body wasn't able to expand and open up. So I have people go through a process that I guide them on how to go from, tummy time to crawling, and then even to relearn how to walk again. But all that sounds kind of complicated. So although I do think a lot of people need this, keeping it really simple and teaching people how that, I tell people, like, you might not have a violet laser, but every sunset has violet light in it. So if you open your mouth at the sunset, you're going to get some ab integration. And a bonus is it's going to help integrate primitive reflexes, those primary reflexes that sometimes don't integrate, that lead to babies who are in this Moro response, or some people that have rigid Achilles tendons. It's not because they need more body work, it's because their primitive reflexes never integrated. And I've found violet light is a quick way to help a lot of these. I wrote a chapter in Suraj Vatish. He's a London tongue tie center release provider. He's amazing. So he wrote a book on tongue tie, and I wrote a chapter on tongue tie and primitive reflexes. I think I was telling you about that because you just finished a massive project, right? You just finished a massive writing project. I don't know if you're going to talk about that,
Yeah,
but I
no,
just remembered. Oh my gosh,
yeah,
that's
the
amazing.
chapters in the medical
Yeah,
textbook.
that's right. So
we've been working it. Yeah.
I'm talking to somebody who knows writing is a task. So yeah, I think integrating diastasis, really often I do collaborate with other providers, but if somebody's going to come to me and they're going to need just what I'm doing, I'm going to do a lot of manual therapy, photobiomodulation, and helping them get into better movement patterns to retrain their bodies.
That's such a great way to summarize that. And my note sheet, okay, I wrote on top of
Oh
all
my
my
gosh.
questions. It's a mess because I have so many thoughts, but that's what I was writing, and kind of summarizing it in my head is that you're doing different manual release techniques, working on movements, integrating different movements, working on coordination and control, and kind of putting those pieces together in the photobiomodulation aspect as well. And that's how we can gain that control over the rectus diastasis, and that impacts also better diaphragmatic breathing for the mouth. And this kind of stepping back, but if someone is asking, what is floor of the mouth? Like, what exact structures are you talking about? Could you clarify that?
Yeah, when I'm talking to kids or even adults, and when I say the word palate, and they're like, "Where's that?" And I'm like, "The roof of your mouth." They're like, "Oh yeah, yeah." Everybody knows the roof, right? Everybody knows the roof. And then I'm like, "Well, for whatever reason in healthcare, we decided a lot of us say the roof, most of us say the palate, but I mean otherwise. If the mouth is a house and it has a roof, it has to have a floor. So if you lift the tongue and you see that band of tissue called the frenum, it's attached to the floor. That's a group of muscles called the 𝐃𝐈𝐒𝐂𝐋𝐀 muscles. And that group, that region, has connection to the mandible, that's the jaw, the lower jaw, and also down into the hyoid, the throat bone, and other structures. So the 𝐃𝐈𝐒𝐂𝐋𝐀 muscles, I used to work on them individually, meticulously working on the digastric. In my opinion, once I figured out the floor four, I realized how they do function as a diaphragm. And when something functions as a diaphragm, there is a concept of fluidity and regional change that I look for to create greater change in the body than massaging the anterior digastric to get it to loosen. And I think that that's the area that for me is not only a place, but it's a function. So the diaphragm of the mouth is the continuum. It's been known as the continuum between the tongue, the frenum, and the 𝐃𝐈𝐿-𝐻𝐼D muscles. But I have research coming out where I've recodified the diaphragms of the body, and I've layered on additional ones to further describe why I think bodies need what we need to give them and heal well. And I've added in how the connection from the 𝐃𝐈𝐿-𝐻𝐼D muscles to the mandible is so important that we can't not include the mandible as part of the diaphragm. So it's a semantic, but those of you out there, you're going to see that's why I say mandibular diaphragmatic, because it's about the mandibular diaphragm. So it's that whole system of integration is based on the mandibular diaphragm and how when it frees as a whole, that's what leads to tongue, roof, craniofacial structure, and down to the feet, getting into a place of suppleness to where we can make significant change. Then I'll say that's what the floor four does, but it also opens the door to then add in layers of sets people up for myo, lactation, and all the orthodontics and all the other therapies. For me, I kind of say that the floor four is a requirement for me within my session, but it's more of the effect. I call this effect colloquially the phase shift. When somebody goes into this phase shift, that's when their calf muscles, which were rigid, become supple and butter-like because of the floor loosening, because of the floor four. So I work for about 15, 20 minutes through 1 to 3 layers in the body, to go to this place to where this shift happens till I see the phase shift. When I get to this phase shift, that's when I start working on architectural change, like the rib cage, or like the tight knee that's injured, or the shoulder that has a problem. If I don't get that phase shift to happen, I have found people need more sessions, more work, and it takes longer and it does not sustain as well. And I compare this to what I was doing before, because I'm like, why does that kidney constantly misalign? Oh, because it needed to be released when they were lying in left side down. When they lie on their left side, gravity pulls the kidney out of alignment. But you know what I found out? That's because of the diastasis, the ab separation. So I look at these complexities as, why is something not working and how can I problem solve that? So bringing it back to the floor of the mouth, I'm sorry. It's hard for me to not talk about the whole body when I talk about the floor of the mouth, because it is one fluid continuum that is very ubiquitous. But to locate it back, yeah, floor of the mouth. And but you know what? I think there's a lot of people, you got some savvy providers who are going to say, Neil, you're only talking about tension, but I'm going to talk about like hypotonic and hypermobility. So weak muscles and hypermobile tissues. Such a big topic in our field. I've been working with hypermobile, from just hypermobile because of injury to mildly hypermobile to Ehlers-Danlos, where they have not only hypermobility, they have autonomic dysregulation and organs that don't work well, and et cetera. And I started to find with the floor four, when I was addressing these areas to get to the phase shift, which is what I teach in my floor four courses. I teach everybody how to get the phase shift to happen. When that happens, it doesn't just loosen tight floor of mouth muscles, because I found on hypermobile patients, the posterior part of the floor, so here's the tongue and here's the front of the mouth, right? And so you have the tongue and you have the frenum is here, whether it be a mucosal, submucosal tie, or an anterior tongue tie, or just the frenum here. And then you have the floor of the mouth here. Often the posterior part of the floor of the mouth, especially on the left side, their left side, when there's hypermobility, it's cavernous. You can push down so far, you would say, oh, that's so loose, there's no tension. But it's a hypotonic. It's a weak floor of mouth and a weak tongue. So what I saw is when the floor four worked, I not only saw the anterior floor of mouth tension decrease on its own, but I saw the hypotonic floor of mouth and tongue muscles strengthen instantly. And there's better tone to the tongue, so the tongue can do that lifting to push up into the palate, push up into the palatine bones to initiate that proper nasal breathing. The floor four works as a modulator, not a thing of things to do or to push on or to loosen or even to tell people to stretch. It's a big differentiation that I wanted to make sure I was saying, that the floor four unlocks homeostasis and balance in the brain, to where then it can tell the mouth, tell the face, the head, and the whole body to go into a better state, a more balanced state. So I feel like one thing that's helped so many of my hypermobile patients is that I'm not loosening tense areas, because a lot of people with hypermobility, and if you know about it, you're like, no, you're hypermobile. There's too much motion. That being said, tongue tie does create rigidity at the tendons in people with hypermobility, and it's still the same points on my map, those 70 points. But they don't need more loosening at all these areas. They need tactical freeing of these four floor and some other areas that might be outside of that to get the floor to strengthen and that tongue to create more suction, so it actually properly facilitates good orofacial function.
Yeah,
Hopefully I
that's
didn't go into
interesting. Yeah, because there's a lot of questions about people with EDS and how to work with them. And if we see there's a lingual restriction, is it dangerous to release or whatever? So that's interesting that your course, your information does address how to handle that sort of discrepancy or confusion people have.
Yes.
And some of the techniques lead me to think sort of concepts of PRI and DNS, so Postural Restoration Institute, with the asymmetries in the body. And I've done some PRI techniques when I was in physical therapy, and a lot of it's movement based. And DNS, I know my husband does a lot of courses with that, and they talk about movement patterns and crawling and working on different areas of the body, like the foot, to release areas in other places. So it's interesting, your techniques, and it all flows with different physical therapy thoughts and philosophies. And I wanted to ask about Dr. Zoggy's protocol. When we evaluate for tongue tie, we always want to look for compensations. And one compensation people may have is that floor of the mouth compensation. So we talk about there's two different ways. You can use the muscles of the tongue itself, or if there's a restriction, you might elevate the tongue by utilizing the floor of the mouth to get the tongue up. So when we evaluate for tongue tie, we might isolate the floor of the mouth. So we might push a gentle push with the index finger at the floor of the mouth to hold that floor of the mouth down to see about tongue tip mobility at that point. And that's how we can kind of see, oh, the patient, they might have good mobility, but they're really compensating at the expense of the floor of the mouth. So I wanted to ask your thoughts on that. What's going on when someone's compensating with the floor of the mouth and how you treat or handle that?
Yeah, well, it's such a great question. But also, I have a huge love of DNS and PRI and so many other disciplines and techniques out there. And I collaborate a lot with PRI. And I think that like what PRI does is what I do not do, and what I do is what PRI does not do, in that very tactically extricating these visceral, the organ restrictions in vectors according to diastasis, taking into account embryological distortions. That's my expertise. So when I collaborate with PRI, I'm like, amazing. I don't need to do a lot of the other things that they do because I can handle the things that nobody else does, which is, or now my students, these three, the only three people who know how to do and the functional mandibular diaphragmatic integration. So my favorite thing is the floor 4 and the FMDI. It's not supposed to replace anything. It'll go inside everybody's systems, just like an adjunct, just like a layer, just like a collapsible and expandable module that somebody can put into their programs to just add in this part. Because my map of the pharyngeal arch formation issues is going into textbooks, which is why I love what you're doing. And it's a different understanding of the body than what exists out there currently. And so while I will say I love what I'm seeing out there, I haven't seen the map in this detail that helps me and others who are navigating this work to that detail. But for me too, when like I love Dr. Zaggy's work, and so I've worked on him in terms of manual therapy for the last nearly 6 years. And in our understanding of what we do, it's so brilliant when he's figured out the things, and other amazing pioneers who have figured out what they've figured out with compensation. And I will give a shout out to you, the myofunctional therapy field. You're the only field that's originated out of issues with the oral facial complex, right? IBCLCs in speech and all these things are great fields, but the myofunctional therapy field arose out of this predicament that we're all in. So I give you all hands down the biggest credit for knowing about the floor of the mouth and identifying compensations. And so then as a manual therapist who brings my understanding of compensation, I do see, if I'm looking at compensation in the floor of the mouth, I'm looking at this 70-point map. Once I got that down, the map that I made and I studied, once I got that down, then I can distill it into these four main regions. And I often find it really becomes very simplified into these four main areas, that when those compensations are addressed, the floor decreases dramatically. But maybe to mention that, it's, what does that mean? When you have cranial distortion and you address that, those are the things that are tense because the floor of the mouth was tight, because of tongue tie, because of narrow arches and palate formation issues. Most people have a restricted right sphenoid. They have a restricted right nasal bone, or maybe even the left. They have a restricted right lacrimal bone. They have a restricted right ethmoid. They have a restricted right zygomatic bone. They may have restrictions on the left side, but it's more predominant on the right side on 90-something% of people with these mouth formation issues because of the spiral pattern that happens. Most of them have a tighter left pterygoid, lateral pterygoid, than a right one due to these compensations. So I think the compensations are many. That's why I made the map of the 70 plus ones. But when I'm looking at a feasible way to address them, they distill down into these four main ones. And even though there are compensations from the ties, from the arch issues, it's a two-way street. So that's why I think we can make changes with the feet. We can do these modalities interventions and create change in the mouth, because the fascial web is very continuous, covering the whole body. So it is It's like saran wrap, or it's like a tug of war. And also we're made with this concept called tensegrity. And maybe you've heard this word. Buckminster Fuller, who is an architect and an engineer who came to California and the human potential movement to Esalen, and he introduced that term that became adopted by psychiatrists and manual therapists and other healers, is tensegrity. There's tension and integrity, that the body works in a scaffolding system of opposing forces. If we take away our bones, yeah, we wouldn't have structure. If we take away muscles, we wouldn't have pulleys. But if we take away fascia, our bodies would collapse to the ground as well. We need that opposing integration of the forces that the web of fascia provides for us to have.
And again, a big takeaway is it's not just about cutting a tissue. We're talking about so many other components that are involved in tongue mobility, floor of the mouth mobility, that if people are thinking of this with a narrow mind, cut a tissue, cut the tongue tie, release the tissue, and everything is resolved, that's not the answer in most cases, right? There's so many other components, and sometimes a tongue tie release is not even necessary when we address these other components. Your discussion keeps bringing me back to that thought. You can't just cut a tissue and be done with this. So that's why all these other therapeutic techniques help improve our outcomes. And I want to ask, when you say you can release a kidney or release, for people who don't understand, what does that mean, release a kidney or release certain areas? And what are you doing? What's happening?
Well, I think like a lot of people know trigger points, where you have this knot, right, of muscle, and usually a knot is pertaining to a clump or of adhesions, a band of tissue that's clotted up, and that's fascia, right? That's when you have that restriction in blood flow, and you massage it. Not only do you break down those clumps of fascia and blood flows through there more properly, but it feels better. Well, it's a subtle difference, but it's kind of like that when I'm releasing a kidney. I'm addressing the ripples of tension in fascia covering it, that obviously I'm feeling the skin or through the clothing, usually, actually. I'm addressing those distortions, but sometimes it's just areas that need a gentle nudge, very light pressure and some movement. And in that way, even holding tension, a lot of the issue resolves. Then the tissues loosen, the fascial adhesions let go, and the body and the brain make the correction to those organs. So some areas need more vigorous work, especially if somebody like this guy, he had his kidney removed from cancer. And so when I saw him and he came in for TMJ and all these problems, even though the right kidney, which is often more associated with floor of mouth tension, was gone, the scar tissue was there. So when I gently worked on those adhesions in scar tissue and lightly massaged the clumps of fascia that had developed, even that freed up the floor of his mouth, because of the way that his body is wired with those of us with these tongue tie issues. If I find an area doesn't respond to light, gentle touch with an organ, I'm never going to dig deep, because I'm really usually thinking, what's in the way of that body accepting that? Is their nervous system regulated enough? Can I turn off the lights? Is there sensory overload? So it's usually gentle nudges when it comes to organs, and it's feeling that sense of melting of tension. But sometimes you hear an audible, that sound when an organ releases, because the body creates that shift and tension releases. And then probably an area that's like a little bit more common too, so some body workers work on this, is the 𝐃𝐈𝐒𝐂𝐋𝐀 valve. It's where the small and large intestine meet. And often when that valve is really tense, you can have constipation, or the other way around, you can have diarrhea if it's not working too well. But so often that is an area that needs gentle pressure and massaging. But while I'm looking for a specific thing to happen with that area, I'm also looking at the whole body tone and the disposition and the blood flow. And I'm looking to stay within a certain range of comfort, discomfort, especially with babies. We're just going to make it the easiest on them as possible. Kids too, right? Kids are running around the room, or even if they're like lying on the table, they're going to let you know with their faces when something is not comfortable. And so I'm going to tone it down and try to work even more lightly with less force. And adults who EDS often has a lot of visceral restrictions. A lot of organs don't work well. Their bodies are so sensitive at times. So you have to think lighter the better, as long as you're making change, because obviously you want to improve things. So sometimes it's just a gentle melting, but then I'm usually looking, how did any of these 70 points in the body change? How did their flora of mouth change? Tongue elevation, palate, and the craniofacial structure, and down to the feet. Because I'm usually going to see a change there if I've affected enough change in these downstream issues.
Okay. So for clinicians and patients, what would you say is required or what is optimal before and after a tongue tie release? What would be the ideal plan?
And I'll stick to the manual therapy part of this, because I'm not going to speak for the myo and for the adjunctive fields where you're navigating with patients in this. I'm going to look at what my requirement is, that I'm saying the floor four, but I hope people know, like, I don't just mean my thing. I mean these areas that I found huge correlation with, that the floor four have been addressed, that layers of them have been addressed, so that floor of mouth tension has a level of suppleness that facilitates tongue elevation, that creates this phase shift through the body. Some people wonder, like, but how do we know? And how many sessions? And yeah, so sometimes I have one session with somebody because they've flown in or whatever, and that's all I can do. So, but then if I have the opportunity to journey with them on sessions to prepare them for the release, and even more, if I can be there for the guided release, to be doing the guided release, or then I'm seeing them post-operatively, I'm looking for some criteria. I'm looking for the floor of mouth to have enough suppleness so the tongue elevates more easily, the orbicularis and the buccinators to become more elastic. I'm looking for sponginess, malleability of the maxillae and the palatine bones. And yeah, my map, I'm looking for change in all 70 points if we can. But if they've got a retrognathic mandible, I'm really looking to see that the proper areas have been addressed to create some anterior migration of that mandible, because it's way harder to address that after the release. And I think some people are relying too much on the tongue tie release to solve the retrognathic mandible, but it's a lot easier to start the process before, if you can. I think that would be like an echoing, preaching to the choir thing, of course. And then I'm also looking to see if their nervous systems are ready, which means just you find when you are working with the floor and elevating tongue, that not only do you feel like there's less tension and there's suppleness, but you can see in their face and you can see in their bodies that they're staying in a supple state, because that means to me they're way more prepared than if they're still feeling stress. I mean, some people will say, but with a tongue tie, isn't there always going to be tightness? Yes, but there's a difference between a rigid frenum and a supple floor of mouth. They can coexist. You can have a supple floor of mouth and have still the rigid tongue tie exist, and lip and cheek ties. So I'm still looking for supple floor of mouth and for improved tongue elevation. And for a myo or for lactation, I'm looking for what I'm doing facilitates their lactation and myo exercises and what they're doing to be happening with relative ease, to where it's not straining them, versus they're saying it hurts when I do these exercises, it hurts when I do these things, or it's really uncomfortable. My helpful thing is when I see people are saying those things that used to be stressful are way less stressful. So I'm looking for that stress reduction pre-operatively. Post-operatively, it's like a blank slate. I'm looking at everything. I'm got all the notes. I remember what we've done, what we've accomplished, but what emerges after release, as those of you out there who work with this, there may be other issues in the tissues that come out to the surface. So I'm categorically looking through all 70 points, but then floor four specifically, to address those areas, to ensure that we are optimizing floor of mouth suppleness, tongue elevation, but also I'm going to make sure I'm seeing change in the maxillae and the palatine bones, the orbicularis oris, the buccinators. I'm leaving out things. Some people might say, what about the masseters? What about the temporalis? All those things are too, but I find those are like secondary, tertiary things to look at versus the foundational ones I'm mentioning, because I find when we're addressing the ones I mentioned, the other ones are just taken care of so much of the time. I like to have an option for 3 to 6 sessions before and 3 to 6 after, if I can. that's awesome. And some people need more, some people need less. It all depends. So I like to have a stair-stepping option for pre and post to see where we're at.
Yeah, that's great. I mean, it's such a great addition to all these other aspects. So if we think of a release as the surgical component, we can think of myofunctional therapy as the functional component. We can think of body work and the work you do also as part of the functional, but part of the mobility aspect, the release aspect, the movement. I'm just trying to put all those pieces together, and it helps our overall goal when we are addressing tongue tie and restricted fascia and the whole body system. And one of my questions, which I think is kind of cool how this kind of wraps up, is one of my questions was, is it possible that the fascial system is the bigger restriction than the frenum itself? And here we go. I think that summarizes this whole conversation as, yes, the whole body system and that sort of spiral, what's the word you used? I wrote it down, but you see the
Spiral pattern.
Spiral tension pattern could be bigger than the actual tissue restriction alone, or could be contributing to the problem just as much. And we have to identify both and address both issues. Does that feel like that's kind of wrapping this up? It's not just releasing a tissue via a surgical laser technique, but it's addressing the other related aspects and components to that restriction that have developed as compensations or developed as that restriction developed, even back in fetal development. We need to attend. It's not a monotherapy, right? Tongue tie release,
Right.
not a monotherapy. Well, how would you kind of summarize this, Dr. Neil, so we really ensure our audience, whether it's therapists, dentists, orthodontists, and also patients and parents, understand this whole big picture?
I would say you said it so well. I'll add another quote. I have this on my slide at the Breathe and Thrive Symposium in Vegas that I was just at presenting. Tongue tie creates torsional debt, DEBT, torsional debt, spiral pattern, right? Spiral patterns in nature exist and they're beautiful. Fibonacci spirals and seashells, and spirals are beautiful. So when we can bring a spiral pattern into its balance, we need it. Springs need to be spiral in order to coil and uncoil. But the debt that these patterns create in the body starts in utero, at gestation, before we're born, when the mouth forms. And until we have those debt areas brought into surplus, nourishment, alignment, sunshine, negative ions, nutrition, movement, manual therapy, myofunctional therapy, lactation, the sound therapy, that's my neuroacoustic part of what I do. Is I advise two companies in neuroacoustics on how sound helps heal our bodies on a very high level. 𝐃𝐈𝐒𝐂𝐋𝐀 is one company, Sound Health is the other. And so we are looking at a time where we need all the resources because there's a lot of debt in our bodies and we need to address these areas. And if we can have the benefit of having this meticulously addressed, we can find these areas that have dragged us down. We can be at a place to where we're more whole and energized and more vitality. So while the tongue tie and the mouth formation issues start the process, it's what's on the other side of that. What does it drag down and create torsional debt with? So I love that I can be somebody who offers some insight on that. And yeah, it's a pleasure and it's a privilege to be able to help people in this. When I'm speaking and presenting at Myosphere this coming spring, and then Infinity, and then some other events coming up, my biggest aim is to get the floor four out there, to become a screening method for those who don't put hands on, to become a manual therapy checklist for any manual therapist, so that every dental office or lactation or myo or any healthcare office has not only my 70-point map, but has the floor four as a rubric and a checklist to make this easier, because this all came through downloads and pattern recognition. I don't think I created any of this. So I want this to be something that gets out there, that is a beyond me resource that can help other people flourish. So I think the one other thing I'll mention is that I'm going to do this webinar on the cosmic mandible coming up in May. And I'm really excited about this because although my floor four courses are coming out, and that's going to be the bigger, broader work, the mandible is such a needed area of help. And I've had so many babies and kids where the parents bring them in. They're like, can you help with these jaws? And I'm like, yes, I can. Let's get them out of retrognathia and recessed state so we can create some more freedom holistically to support your other processes. So in May, I'll be doing this on how to get these retrognathic mandibles, hypersensitive gag reflex, swallowing, all the things that we talk about, but very specifically how people can lay a hold of these resources.
One thought that came to my mind, and then I want you to let everyone know how they can get information on your courses and everything. But one thought as we're talking about the big picture here is, I remember Dr. Mark Cruz put up a slide years ago. I think it was at the International Association of Oral Facial Myology, the IAOM convention in San Diego, a long time ago.
Yeah.
And he put up this slide. It was split in the middle, and there were two, almost like looked like the same person on a balance board. And on one side, the person was just balanced fine. The other side, they were still balanced. The board, they weren't falling over. The board was, even, but the person was all crooked and off, but they were still balanced on the board. And he asked, which one is in homeostasis? And everyone's looking. And the answer was, they both are, but one is compensating to get there. And it makes you think, we can look balanced and function, but the body will pay a toll if we're compensating to get there. So by attending to all of these compensations, releasing, those spirals of torsion, debt, as you said, can help us lead more relaxed, freer lives, achieve these goals easier. So that's why I think your big picture of attending to whole body is a really important aspect of this. We have a lot of people functioning, but compensating and straining to get there. And I just thought that was a really neat visual. I'll never forget when you put that in his presentation. And this has been really informative. So great to hear about all the work you do and how you're spreading this message, and how this is another component it's not new. This is not new information. You didn't invent these things. You see and saw this pattern, and you're putting those pieces together in programs that can help patients of all ages. And I think that's really wonderful. How will people learn about how they can take your courses and what's going on? Do you have a certain website, or how can people learn about this?
Yeah, my website is my name, neilbulchandani.com. So NEELBULCHANDANI. I know we have the links to it. So if you're listening and you Google Neil, NEEL, and floor to the mouth, I'll come up. And then if you look at my Instagram, Dr. Neil Bulchandani, that's where I am most active. I'm also on Facebook at Neil Bulchandani, DC. So any of those places, but especially my website, there'll be a place you can scroll to the bottom if you want to just put your info in and get on a update and newsletter updates so you can stay aware of when the webinar launches and other updates on the courses that I'm doing.
That's great. And it sounds like the work you do can be helpful for all, of course, families, patients, but all different types of practitioners to learn about this, better help their patients or refer them to people who can help, just to be able to identify these other components. But also, I feel like physical therapists could also benefit from your information a lot.
Absolutely.
PTs who might not have this specific training in tongue tie, floor of the mouth, and that whole aspect as well. So this has been really great. Dr. Neil, thank you so much. I know you have a busy day. Now you have a 3-hour patient coming up. Yeah. So hopefully you'll get your lunch break in, and we will share this with everyone. Thank you again for being here.
Well, thanks so much for having me. This has been exciting to finally have this conversation with you, and I really enjoyed it. Thank you so much.
Thank you. Have a great rest of your day. Take care. Bye. Thank you so much for joining this episode of Airway Answers. I'm hoping some of your Airway questions were answered. Please feel free to give us a rating or a comment. And if you have any further questions, you're welcome to email me at nicole@airwayanswers.info or check out our site at www.airwayanswers.info. Thank you so much, and join us for the next one.